Yeah, okay. Thank you. And it's a real pleasure to be here. I don't know, it's like my 15th year, and this has been one of my favorite meetings ever, and I'm happy to come and proud to be part of it. So about 25 years ago, this guy calls me in my office and says, "Hey, I got this new blood test. It's a hormone for heart failure." And I said, another one of these crackpots is calling me. And it turned out that it wasn't a crackpot. And some of you know him, it's Scott Mader. And the hormone was B&P, which is now the gold standard diagnostic for heart failure. And he called me about 5 years ago again. And he said, "Your stethoscope is killing my patients." This crackpot's back again. But you got to listen to some guy who invented B&P. So this is me in my hospital. This is pre-COVID, and I'm about to see a 14-year-old girl who's got chronic lung disease, and I'm required by my hospital policy to do this. And so I put on my gloves, and I put on my mask, and I put on my gown. But if you look real closely, you see my stethoscope is just hanging out there with just going to go rub it on her, like we always do. And that's what my hospital policy, and this is me in COVID, and it's no different in COVID, except I wear this silly mask. My stethoscope is still hanging out there in the wind to touch people. And so I started looking at the data on this, and this is the data on your hands, and the blue numbers are total aerobic bacteria counts, and the red are MRSA, methicillin-resistant Staph aureus. And you can see there's a whole bunch on your fingertips. And we wash our hands between every single patient. In fact, I'd get fired if I didn't do that. But if you look on your stethoscope, the total counts exceed everything except the fingertips on the diaphragm of your stethoscope. And I'm thinking, well, I've never washed well, that's not true. I've washed my stethoscope sometimes. But if you think about it, the hand is a glove, but we don't have gloves for the stethoscope. And I want to ask you, how many of you guys wash your stethoscope? How many wash it between every patient? Okay, so I'm going to show you some data on that. So this was a study we did. It's our ambush study. And we literally would walk down the hall and ambush a doctor or a nurse or a medical student and say, "When did you wash your stethoscope?" And they say, "Oh, I just did it." 86.5% of them said they just did it. And they did it according to the CDC guidelines, which if you read them, you're supposed to wash it for 60 seconds with an alcohol swab with isopropyl alcohol on it. And I'm thinking, really, you did that? So we cultured it right there. Well, it turned out that 76% of the medical students had bacteria on their stethoscope, and 91% of the doctors did. So we've proven the doctors are dirtier than medical students. But the truth is, either they are lying to me about cleaning their stethoscope, or washing doesn't work. And I don't care about the answer of the truth here because it's dirty, and that's the bottom line. These are two studies that we did, one in my emergency department, one in the VA hospital in San Diego. And what we did is we wandered up there, and I had a medical student with a clipboard and a white jacket run around and just watch people interact with the patients. And they did it a lot. There's 400 patients. And at the end of that, and this was in the ICU and the ER and labor and delivery in the OR, places where you'd think they'd be washing things, the total number of washing stethoscopes between patients by the CDC guidelines was 4%. 96 of them didn't do it. And then we repeated the study at the VA hospital, it was the same thing. So 800 patients, you're more likely to get stung by a bee than get a washed stethoscope. And I talk to people that and go, well, do I really need to wash it? Are there any randomized controlled trials showing that it causes diseases? And I'm sitting there going, randomized controlled trial. Okay, so you're going to walk up to a patient and say, "Hey, dude, I'm doing this study where we're going to rub pathogens on you and see if you get sick or not. Will you sign the consent form?" And there's nobody going to sign that consent form. It's the same thing as the parachute. We don't have a randomized controlled trial. The parachute works. So we're never going to have one on stethoscopes either. We can only do registry data or things like this. And this is where this guy named Thaker took cauliflower mosaic viral DNA and stuck it on the stethoscope, and then went to a mannequin. They examined the mannequin, and then they went to the next door mannequin, and they examined that mannequin, and then they cultured the second mannequin, and 28.3%, 41 of the mannequins had cauliflower mosaic virus on them from the first mannequin. So it's clear about 28% of the time you can do a pretty good job of moving bugs around with your stethoscope. This is just a couple papers on that. Connect was looking at bacterial populations, and it shows that you can't clean them off your stethoscope, and the guy on the right, Palmer, did it with 65% alcohol and then cultured the stethoscope, and it's 28% still. You cannot clean your stethoscope even when you do a good job of it with alcohol. So clean it all you want. Unfortunately, it doesn't make much difference. And I'm pulling out C. diff here specifically because C. diff doesn't get killed by alcohol. It goes into spore form and it sits there, so you have to use the special C. diff killer on it, and if you don't, where's Luella? This is from her hospital. They went and cultured a bunch of stethoscopes from doctors and found out about 5% of them had C. diff on them. The crazy thing about C. diff, it can last for a year on a surface as a spore. So if you've seen one C. diff patient in the last year, you might be one of the 5% who's got C. diff on it, and that kills about 39,000 people in the US a year. This is a trial where they put C. diff on stethoscopes, put them on a mannequin, went down to the next door mannequin, cultured them out there, and somewhere between 25 to 75% of the mannequins had C. diff on them from the first mannequin. So it's pretty clear that I don't have a randomized controlled trial that you can infect people with your stethoscope, but it's pretty clear you could. So this is what the crazy idea that Scott came to me with, was that device up there. You walk up to it, you wave your stethoscope, a little barrier comes out, you stick it on there, and you go see your patient. It takes about a second. You don't have to wash your stethoscope anymore because it takes 2 seconds and you throw it away when you're done. It's acoustically invisible. There's 400 in a box, and that's what it looks like. So I did a study on this. I took a bunch of stethoscopes, and I put stool and infected urine, you get this stuff out of the freezer of Lab Friends, sputum, infected blood, and smeared it on the stethoscope, and it didn't smell good at all. And we set it there, and we put them into the incubator, randomizing some to barriers and some to not. And we pulled them out every few hours and up to a week. And a week later, this is what you get. Those are all the controls and the actual cultures on there, so there's bugs on them. We put them there. And the ones that had the barrier had no bugs. They were sterile. Up to a week. Now that barrier is supposed to be disposable. You're not supposed to use it for a whole week, but it just shows it works. And the next question is how much does it screw up your stethoscope? Because if it screws up your stethoscope, what's the point? So I have a friend who's a residency director. We ran his entire residency class through the simulation mannequin. They either used a $627 Littman 3200 recording stethoscope with or without a barrier, or they used a disposable stethoscope. And we just saw how well they did. And these guys were surprisingly good. There are 800 auscultations. In the red there was no difference with the retort. They got 100% right, which I was really surprised because some of these diastolic murmurs are difficult. They got 100% right if they use a digital stethoscope. With or without the barrier, it didn't matter. If they use that crappy disposable toy stethoscope, which I hate and I find in my ER all the time in the negative suction rooms, you missed 1 out of 10. So the number needed to harm is 10. Every 10 patients, you blow the diagnosis. And they always blew the diastolic murmurs. So they missed the heart failure patients, and that's the problem. So then I did a study here to see if this thing worked at all. And so it was pretty easy. I put a iPad next to the box and said, here, when you're done using this, just fill out the iPad. And this is what they said. So did they like it? Well, 93% of the people thought it was better than cleaning their stethoscope for 60 seconds with an alcohol swab. And they felt it was an improvement, especially over the disposable stethoscopes, which we all know aren't very good. And then they thought it had at least a benefit to their workflow, because if you really do clean your stethoscope, it takes time. I see 50 patients in a busy ER shift. That's 100 minutes of stethoscope cleaning that I just don't have. I barely have enough time to wash my hands. And they also believe it improves stethoscope hygiene. And they believe it will improve patient safety, and you can see the C. diff number there. Cost-wise, this thing's a quarter, 25 cents. I guess in euros it would be 30, almost the same nowadays, since we've sort of equalized. But if you get one case of C. diff in your hospital, it's 50 grand, $50,000. So you stop one case, you just save that much money. That's enough money to buy these things for a whole year. This was the call to action that was published about 6 months ago, asking the CDC to update its guidelines. I can't predict what the CDC is going to do, but this is an option that we never had before. Their old guidelines say, clean your stethoscope once a week unless it's visibly soiled. And it's like, visibly soiled? Because I have, microscopic vision. So hopefully the CDC is going to upgrade that soon, and we'll see a change in this. But I'll apologize now, because the next time your doctor comes to you with a stethoscope, you're going to wonder, did you wash it this year, buddy? Every time. So let me summarize. That's Ignaz Semmelweis on the left there, the bald-headed guy with the QR code on his forehead. The QR code is where to get the box. But Ignaz Semmelweis was the guy who came up with the idea you should wash your hands or you'll kill your patients. That was 150 years ago. And if you ever study this guy, he was completely ostracized, told he was a kook. All the famous people hated him. He ended up dying in an insane asylum about 5 years later. So I'm not going to the insane asylum. But it's pretty clear that stethoscopes can transmit bugs. It's pretty clear that nobody cleans their stethoscope between every single patient. And even when they do, 28% of the time there are bugs on it. These barriers look like they seem to work. We've published enough, I think it probably is. So thank you much.
Very good, Frank. Any questions from the audience? Professor Mills.
Brilliant talk, Frank. Always make me think differently. So did I hear you right, that you are going to use these for the next year in your hospital? Is that the outcome of this?
So what I did is I got a portable box and I put it in my trauma area because we get blood. You know, when like some guy comes in, you tube him, you have to know where the tube is immediately. Everybody says, well, I don't use my stethoscope more. I use ultrasound. It's like, there are things you cannot use ultrasound for. So, and that's our bloodiest place. Our stethoscope's bloody all the time. It had 400 stickers in it, and it was gone like in 2 days. And I had the residents chase me down the hall and say, we need this thing because I'm tired of cleaning my stethoscope. They actually do clean their stethoscopes, as we showed. Residents are cleaner than attendings. But and so that is expanding in my hospital. But that's where we are right now. At the moment, there's one because that's all I could get from the company. But they'll change that.
It would be great to look at, hospital-acquired infections before and after implementing it, if you do introduce it widely. Because you present a compelling case and it makes perfect sense. But I think if I were to go back to my hospital and say, we need to do this, they'll raise an eyebrow and say, really?
It needs to get enough market penetration that we can show that hospitals that use it have lower rates of iatrogenic nosocomial infections than hospitals that don't. That's the critical switch in the clinical practice.
You said it's the third hand of the clinician. Our fourth hand is the ultrasound probe.
Okay, so I'll tell you, I took this box and I put it on the ultrasound probe, and it's invisible. You can't tell it's there. So you can, like your butterfly, that works fine. The sonocyte, on certain probe covers, it causes lines that interfere with the interpretation of the view. So, but if you don't have a sonocyte, it seems to be okay. And I talked to the company, Scott Mader's company, about doing this with the ultrasound, and they're looking at different, because it's going to be a different latex thing to cover it. Technically, it can't be latex, but it'll be some other kind of plastic. But that's coming, apparently.
Frank, congratulations. Always very innovative. One point is now in COVID patients, we are making so attention to try to reduce the infection. Do you have any evidence in COVID? But at the end of the day, when we are putting the stethoscope, we are putting the real stethoscope on the chest. And do you think this is also a way to spread the COVID infections, or you can also reduce the virus? Because in your paper, you show that having bacteria reductions. What about virus?
Yeah, so I tried to do a COVID trial, and it just was so difficult to get people to go into COVID rooms and have them cough on the stethoscope and go back and do it, which is the way to do it. But Alan Mizell has published the case of a cardiologist I think she was from Saudi Arabia, who was wearing the full gown, had to open her gown up to get her stethoscope to listen to this person she'd intubated, then pulled it back and closed it. It was her only exposure, and she got COVID. And so that's in the literature. It's not really a great trial. You know, it's some guy's opinion of a case report, but that's all that's in the literature.